Welcome to this month's Coffee Chat. Today we'll be focused on coronavirus, and we're going to begin with a brief primer on epidemiology and the SIR model, which stands for susceptible, infected, recovered. And this is the base model for epidemiology, and then we get more complicated as we go further. So this is just the most basic foundation. We're going to be addressing several questions with this basic model, like how long will people be sick, how many people will be sick. If you do an intervention, can you estimate based on the model how that will impact it in terms of time to recover, in terms of peak, number of people getting sick. We'll also talk a little bit about contact tracing when it's effective, and what are some of the common problems with modeling infectious disease. So let's begin with the basic SIR model. We have some variables that we need. The first variable is time, which is your independent variable. That'll be along the x-axis. And then we have other variables that are important for this model, like the number of susceptible individuals. These are the number of people that could potentially be infected. We have the number of infected people at a given point in time. We have the number of people that were recovered at a given point in time. And then we, of course, have the total number of people in the population. So it's important to note that the sum of those that are susceptible, infected, and recovered equals n. So in this basic model, there's nobody that will not fall into one of those three categories. There's a few other assumptions. We assume that there's no additional people being added to the susceptible group. There's no births or deaths going on in that way. The only way to leave is being infected is the only way to leave the susceptible group. The number S depends on the number of susceptible and the number of infected and the number of contact between them. We assume that an average person has B contacts per day. And so then each affected individual is going to generate B times some rate of adding susceptible people per day. So I'm using that lowercase s to indicate more of a rate than I am a total number. And then we have a fixed fraction K of individuals that are going to recover each day. So it's easier to work with fractions. So basically you'll see me divide the total number of people by the total number of susceptible, infected, recovered by the total number of people. So that'll give me a lowercase s of t, which will be the rate of, the fraction of change. And then the rates are going to be a series of differential equations. So if you're not familiar with that notation, the little ds over dt is the change in the fraction of susceptible over time, and that is going to be equal to a negative b, that's the number of contacts per day, times the fraction of susceptible times the fraction of infected. And then our change in the number of recovered over time is going to be that k, that fixed fraction of individuals that are going to recover each day, times the number that are infected. And then the rate of infected over time is going to be B times the STIT, which is, again, as you recall, the number of people susceptible minus the number that are recovered. And then the sum of those three differential equations will be equal to 0. So that's our system of differential equations. Now, I'll work out an example using New York City's Hong Kong flu of 1968. Now, what's interesting here is it originated in China in July 1968, lasted until 1970. So I think that this is kind of very interesting as we are looking at coronavirus. The Hong Kong flu was the third pandemic of the 20th century and had an estimated 4 million deaths, which was far fewer than the 1918 flu of 40 million deaths. So just to give you some sort of scale or benchmark. So in New York City at the time, 1968, there was 7.9 million people. We're just going to assume that there was an initial 10 people infected. And of course, at time 0, there was 0 recovered. Total number of population is at 7.9 million. So when we work out our system of equations, right, we can identify some of these basic initial points for time 0. What we don't have is we don't have the B and the K. And so that's what we fit to the data that we see so that we can estimate a model. So how do we estimate them? Well, we look at things like the excess death rate. We look at theoretical models of interaction dynamics of how we think they're going to interact. Or we'll do some clinical observations based on like looking at the number of patients and how many recover from that perspective. So we're going to assume for this model that the B is 1/2 and the K is 1/3. And so then we can now generate a model where the blue line is showing the number of susceptible people, and it's assumed in this basic SIR model that once you have been infected, that you don't have the risk of becoming reinfected. You've developed immunity, which is not always the case, but for modeling perspective, that's what we have. The green line is going to show the number of people that have recovered, and so then it kind of levels out at this equilibrium here. And then the red is the number of people that are infected at any given time. Okay, and so that's for New York City. Now, we can improve or add to that model, and so here's a website if you want to play around with one of these. But you'll see here on the left, right, they've made a slightly more complicated model. So we have susceptible, exposed, right, which is the population that's currently in incubation. So we're adding that dynamic. The number infected, the number removed, the number recovered, the number hospitalized, the number of fatalities, right? So you've gotten a little bit more complicated than just 3 steps. And so as you decide to make this model more and more complex, right, you can add more components to that and then start chaining them together. And then it might be better to do this in a simulation or a numeric approach, or you might choose to analytically derive the equations if you can do so. And then you'll see that down here at the bottom, there are slider bars to address the things like the transmission time and the morbidity statistics, recovery times, care statistics, and others, right? And then what you'll see is up here, they're going to show this rate parameter called R0, which is essentially similar to that parameter B that we showed in the SIR model. So R0 is basically how many people are going to get infected from one person infected. And so right now for coronavirus, in the literature, that's estimated to be about a 2.3. And so you'll see that there's this exponential growth in the number of people that are exposed and the number of people that are infected, and even to some extent the number of people that are hospitalized, and the fatalities is very small. Now we're assuming that what happens if we do some sort of social distancing to lower the R0, and so in this case we've lowered the R0, and then you'll start seeing that social distancing causes that taper off of the rate of the number of people that are infected. So what happens if we make a change to one of the parameters, right? Well, then you notice the R0 still remains the same. Here it's a little less than 2.3, and it kind of flattens out and isn't doing as much as we thought, right? It's just leveled out. It's not dropping off, right? And you still see the number of infected increasing, the number of hospitalized increasing, the number of fatalities still seems to be linear. What changed? Well, the transmission time, right? So as the transmission time between people lengthens, then a lot of these things lengthen. The other one that's probably more important for us is currently our estimates of the social distancing don't get the R0 below 1. And so when that R0 does not get below 1, it does not create a downward trending equilibrium at all. We're going to go a little bit more complicated, and we're going to look at something called a heterogeneous mixing model. Now with the heterogeneous mixing model, this is going to look at 2 different populations that have different risk factors. Now there's a couple ways in which you can use this model. One is we could model the impact for a government, generic government field office within a larger population. So we could say, hey, how can we understand interventions we do to this subpopulation in this government office within the context of the county of people that they're dealing with? Because you might be able to impose certain social distancing or certain precautions within a given field office, but you can't really affect the culture or the broader community that that group of people is embedded within. So that would be a way to kind of look at 2 different populations. Another way to use this is if we segregate the number of people that are of older age, that smoke tobacco, or that have pre-existing health conditions and are at greater risk for the disease, we can look at that population, again, within the context of a broader population, so we can understand how do interventions we do targeting at-risk people, how do they impact the fatality rate within the context of this broader population that they're in. So, here is some R code, and you'll see that S1, I1, R1 stands for the SIR for population 1, and then we have S2, I2, R2 for the population 2. And so what you'll end up seeing is that if you just model the number of cases, and so we've modeled that there's a certain transmission rate within population 1, the same one within population 2, but then there's a different rate of contact between population 1 and 2 or between 2 and 1. So what you'll see slightly different curves based on those two different populations. Now what's interesting is what I'm showing now is what happens when you target the high-risk population only. So that's the slightly lower curve. If you target the high-risk population only, the black is showing the baseline of what that infected curve is for the whole population. When you target just the high risk, you see a small reduction. When you target just the low risk, so these are the people that aren't necessarily at risk, right? You see a much greater flattening of that curve. And then if you do both, of course, you get an even greater flattening of the curve. Now, there's a couple things here. One is it's intuitive to say, well, we should focus our treatment and our policy on the high-risk people that are affected, right? Why don't we just make the old people stay home or wear a mask, right? But we actually see that treating the broader population that does not have as much risk is going to have a greater impact overall on the epidemic. And that's slightly counterintuitive. So let's talk a little bit about contact tracing. So you've heard a lot about contact tracing, and those are the process of identifying persons who may have come in contact with infected people. It's often done with sexually transmitted diseases, vaccine-preventable diseases, right, like smallpox or polio, bloodborne diseases like hepatitis C. A lot of bloodborne diseases are done through IV injection users. And then novel diseases like coronavirus, just to understand how those dynamics are, because you don't necessarily know what's causing the disease initially. And there's always this ethical concern because contact tracing is somewhat invasive. I mean, especially imagine the sexually transmitted disease example, right, where you're going to ask, who have you had sexual contact with in the last 6 months to a year? That's very invasive. And so there's this trade-off between the duty to warn the population of an epidemic or of learning what we can do to kind of protect people versus the individual privacy in asking these kinds of questions. So what I'm showing you here is what we call a two-mode network from the SARS epidemic. And so the white and red circles indicate people, the red being infected, the white circles being uninfected. And then those blue diamonds or those black squares indicate either hospitals or locations. So what we're doing is we're using this to kind of understand who has been in contact with key locations where there's been a transmission or likely transmission, and then try to use that to understand how the disease might spread. And we do some more advanced social network analysis on this. Like, we can collapse this to show the people-to-people transmission. We can identify what's the most central location, what's the most central individual. We can use that to begin to understand properties of what that B is for contact, what that K is for recovered within the context of the network that they're operating. Here is a very famous one. It's since been disproven, but this was considered patient 0 for the spread of the HIV epidemic. And what I mean by disproven is patient 0, I forget his name, but he was a flight attendant, was vilified for a number of years for being the biggest HIV spreader, and he probably was. He traveled, from New York to Los Angeles, and then would spread, would have sex with people at bathhouses in both locations, and then that would kind of spread the HIV from one place to the other. By disproven, what was disproven was that HIV actually existed in the U.S. as early as the 1960s, and that was clearly before patient 0 was of having sex age. So he didn't necessarily bring HIV to America, but he was involved in spreading it. And so contact tracing was very important for us to understand even that it was a sexually transmitted disease, let alone how it was transmitted, and begin to develop solutions. Here's an advancement that we've had at Johns Hopkins. We do something called phylogenetic networks. So for hepatitis C, we can actually take blood samples of people that have hepatitis C, and we can actually look at the strain of hepatitis, and we can see who has injected drugs with whom So you can start building out these drug injection networks that allow us to begin to understand who we need to treat at once. Because while there is now a treatment for hepatitis C, it costs about $100,000 as of the recording of this to treat a hepatitis C patient. And then if they go and inject drugs once they're cured with somebody with hepatitis C, they just become reinfected again. And so it's very important to treat the population at once. And there is a goal to try and eradicate hepatitis C by 2030. So I'm not really prepared to comment on how well we're doing with that, but that's the goal. So with all of these contact tracing, right, from doing two-mode networks to individual networks to even phylogenetics getting super fancy, they're not appropriate when the infectivity is high. So they're much more appropriate for HIV, which has a very low infectivity and requires exchange of bodily fluids, which is fairly difficult, or even IV injection, right, has a lower infectivity rate. When infectivity is high, these contact tracing models, these social network methods, are less effective, and that's because it's so high that it's equivalent to chance contact. So things like coronavirus with an R naught of 2.3, that's going to be what we would call high infectivity, and we're not going to necessarily need to use contact tracing to create interventions or interdictions for the spread of that disease. So some interesting research questions that we're exploring. One is to implement a more complex SEIAR model. Now what that does is that has a susceptible, exposed, infected, asymptomatic, and recovered, and that was published earlier this year. And so including asymptomatic patients is an important dynamic, as you can imagine. And so we are implementing that model. We are looking at modifying models with more accurate ST and IT. So we've learned in the medical literature for coronavirus that about 50% of individuals that are infected are asymptomatic. There was a great natural experiment with a ship off the coast of Japan where the Japanese government tested everybody, and they found that 50% of infected people were asymptomatic. So we believe that if that holds, right, that's a significant difference in the number of susceptible people, and it also adds this really important component of tracking the number of asymptomatic people. We find that 20% of symptomatic people seek treatment based on other literature, and so these numbers significantly impact the rate of mortality and recovery. We want to model different contact values for different counties based on things like, you can imagine that the public transportation, the population density, the compliance of social distancing, some of these factors are going to affect your your rate of contact and your rate of transmission, and so we want to be able to model those differently for each county so that we get a more accurate county-by-county estimate. We also want to model different K values for different population demographics. So we might think that, that the recovery rate is going to differ based on things like age, smoking status, pre-existing health conditions. So getting that kind of data would be important. We want to consider modeling heterogeneous mixing for different federal offices so we can evaluate a differential risk at different locations. The force protection posture you might take in New York City probably going to be different than like Helena, Montana, for example, or Tampa, Florida. And then we also want to model economic impacts to conduct trade-off analysis between what is the cost of our economic shutdown versus disease impacts. And can we put a number on that? How long do we need to actually contain or continue a social distancing process, and how strict should we be on enforcement of that, given our democracy, given the impact to public health, a variety of issues. Hope you enjoyed this coffee chat, and hopefully you finished your coffee and are ready for another one. Thank you.